Good morning. Thank you all for joining. I do have this in the chat. If you would like a question, please post that you would like to ask a question in the chat, or if you need record access, I'll begin granting record access momentarily, and shortly thereafter we will begin.
This meeting is being recorded.
Dan, this is Alicia. Can you hear me on a mic check?
Yes, I can.
Great. Thank you very much. Just one more moment. We have a few people coming in from the waiting room, and then Dr. Vanderhoff, I'll turn it over to you.
Very good.
Okay, Dr. Vanderhoff, I'm doing the last admission from the waiting room, and we can go ahead and begin. Thank you very much, sir.
Well, thank you. Well, good morning, everyone. I'm Dr. Bruce Vanderhoff, the Chief Medical Officer for the Ohio Department of Health, and I want to thank you for joining us today. As I'm sure you know, the CDC's Advisory Committee on Immunization Practices, the ACIP, began meeting yesterday. As a part of this meeting, the group of medical experts there discussed at length mRNA COVID-19 vaccines and the conditions myocarditis and pericarditis. And what I want to highlight is that thanks to the extensive safety monitoring systems in the United States, we can really have confidence that we have the systems in place to identify this risk, though it is very small. These discussions, I think, are a poignant example of the vaccine safety system working exactly as it should. Now, myocarditis, let's talk a little bit about that. It is an inflammation of the heart muscle, which can reduce the heart's ability to pump and can cause rapid or abnormal heart rhythm. So the signs and symptoms of myocarditis include chest pain, fatigue, shortness of breath, arrhythmias. Pericarditis, which is a very similar condition, is a swelling or irritation of the membrane surrounding the heart. These are very closely linked conditions. Well-recognized causes of myocarditis include some viral illnesses, including COVID-19, bacteria like strep and mycoplasma, and even some medications like antibiotics that are used commonly. Following the ACIP meeting yesterday, the CDC, along with the American Academy of Pediatrics, the American Academy of Family Physicians, the American College of Physicians, and many others, are now very clear that this is an extremely rare side effect that only affects a very small number of people following vaccination. And importantly, for the young people who do experience myocarditis or pericarditis, most cases are mild, and the individuals recover often on their own or with minimal treatment. In addition, the ACIP pointed out that myocarditis and pericarditis are common. And these experts note that if you get COVID-19, the risks to the heart from COVID-19 infection can, in fact, be more severe. Now, many young people in this country have already been vaccinated. As of yesterday in the United States, almost 21 million individuals up to age 24 had received at least one dose of the COVID-19 vaccines. Further, about 7.6 million of those under the age of 18 had started the vaccine process. And here in Ohio, close to 1 million people under the age of 30 have started the vaccine process. So, while there appears to be a very small risk of myocarditis after receiving a COVID-19 vaccine, as the ACIP discussed, the benefits of these COVID-19 vaccines clearly outweigh the risks. For anyone, the risks of COVID-19 are great and can, as we know, include hospitalization and death. In fact, 2,767 COVID-19 deaths have been reported among people aged 12 to 29 years, with 316 of those deaths having been reported just since April 1st. And let's not forget that COVID-19 itself can result in myocarditis. Now, as the highly contagious Delta variant begins to spread through our country, there's really no time like the present to make the choice to be vaccinated. Today, I'm honored to be joined by two medical experts to discuss some research about cases of COVID-19 and myocarditis unrelated to the vaccines, the difference between cases of traditional myocarditis and post-vaccine myocarditis, and the risks associated with COVID-19 for those who are unvaccinated. First, I'm joined by Dr. Rajpal. Dr. Rajpal, you and the team at the OSU Wexner Medical Center have had research published in JAMA Cardiology about athletes and myocarditis. In your study, you conducted MRIs on Big Ten athletes who had COVID-19. Can you tell us about this research and your findings?
Thank you, Dr. Vanderhoff. We collaborated with our Big Ten colleagues and collected data from March through December 2020 on competitive athletes who got COVID-19. Of the 1,597 athletes, 37 or 2.3% developed clinical or subclinical myocarditis. 9 had clinical myocarditis and 28 had subclinical myocarditis. And of these, the overwhelming majority, 73%, were males. So these are some of our important findings.
So your research found that there were about 2.3% of athletes with COVID in your study who had myocarditis as detected on an MRI, meaning it could have been symptomatic or asymptomatic. That's a much larger figure than the CDC is discussing with post-vaccination myocarditis. There are patients and parents out there who are concerned about myocarditis. As they think about the risk associated with myocarditis in patients who become ill with COVID, what can you tell us about the impact of the COVID virus on the heart?
The concerns of the parents are understandable. However, risk versus benefit analysis is at the core of any prevention or treatment strategy. Based on the CDC data that was presented yesterday, the estimated rate of myocarditis is 12.6 per million second doses administered. If we compare this number to clinical myocarditis in our cohort, the risk is much lower, about 400 times lower. Even if we compare the highest risk group, which is the 12 to 17-year-old age group of males, the estimated risk is about 70 per million second doses administered, which is still about 70 times lower than the risk of myocarditis with COVID.
Thank you. That's very enlightening. Now I'd like to turn to Dr. Lee from Nationwide Children's Hospital. Dr. Lee, you've treated patients with myocarditis in this younger age bracket. What's the difference between a patient who has vaccine-associated myocarditis and any other patient who comes in presenting with myocarditis?
Thank you, Dr. Vanderhoff. As you mentioned, in general, myocarditis is an inflammation of the heart muscle, and it presents similarly in children as it does in adults. And like any disease, there's a spectrum from mild illness to severe disease. So a more mild case of myocarditis may demonstrate evidence of heart muscle inflammation, which again is kind of what the core of what myocarditis is, as well as some evidence of injury, but because it's mild, the heart muscle can still pump or squeeze normally. Now, there is a spectrum, and we've seen more severe cases, and in those cases, that inflammation begins to affect the heart muscle function and cause it to become weak and pump less vigorously. So because there is this spectrum, most patients who have myocarditis or who are diagnosed with myocarditis are admitted to a hospital to monitor to ensure that they're not developing that most severe form, which we call fulminant myocarditis. And children with fulminant myocarditis are very sick and typically require admission to the intensive care unit and become so sick that they need to be placed on a mechanical life support system, also known as ECMO or extracorporeal membrane oxygenation. Their illness can be complicated even further by heart rhythm abnormalities or arrhythmias, and also multiple organ failure such as kidney failure. And all of these things can contribute and ultimately lead to death or need for heart transplantation. Fortunately, fulminant myocarditis is less common than the more mild forms of myocarditis, but it is something that we can see in children. And now in terms of the vaccine-associated myocarditis, fortunately, most of these reported cases appear to be mild and to resolve without treatment or significant intervention, as you mentioned. And the same appears to be the case for children or teenagers with vaccine-associated myocarditis. Thankfully, I'm not aware of any patients yet with vaccine-associated myocarditis who have had fulminant myocarditis, which again is this most severe and dangerous form, although certainly this is still being monitored very closely, as you mentioned, and we will have to keep looking into this and seeing if anything changes, and also looking to see what the longer term holds for this.
Yeah, thanks. You know, one of the important messages that we've been wanting to communicate, especially to parents, is that COVID-19, while thankfully has a mild impact on so many children, can cause very severe injury, very severe illness in some children. As a pediatric cardiologist, could you share a little bit more for us about what you see in the spectrum of children who require hospitalization at Nationwide Children's due to COVID-19?
I think the biggest impact that COVID-19 has had in pediatric patients has been MIS-C, or multi-system inflammatory syndrome in children. And I think this is the biggest risk for pediatric patients. MIS-C patients often have a very severe form of myocarditis as part of their illness, and involvement with the heart is one of the leading involvements or organ systems that are involved and affected by MIS-C. Thankfully, it's not very common, but again, children who get MIS-C, most of these will require admission to the intensive care unit. And like I mentioned with fulminant myocarditis, a small number will go on to require mechanical life support or ultimately die. These are also mostly healthy children. There was a recent study that looked at some of the demographics, or just, what is the makeup of these kids that are diagnosed with MIS-C, and they found that only 25% of them had a prior medical problem. And so again, these are mostly healthy children who are coming in and becoming very ill. Some recent data also, again, similar papers looking at the makeup of the kids that get MIS-C after COVID-19 or SARS-CoV-2 infection have shown that older kids actually are at higher risk for being sicker with MIS-C. And a recent paper found that kids 13 to 20 years of age were actually more than twice as likely to be critically ill and need ICU care compared to younger kids, the 0 to 5-year-old age group, which is what they compare to. And I think aside from hospitalization and aside from MISC and myocarditis, I've certainly seen a lot of healthy teenagers who come to us after, come to us after SARS-CoV-2 or COVID-19 infection, are sent for sports clearance to our clinics. And some of these kids have very significant symptoms. Some of them can have long-standing shortness of breath or trouble catching their breath, chest tightness, and fatigue. And sometimes these symptoms can last for weeks and weeks and interfere with the quality of life and just getting back to sports and regular life in general. So I think while it's true that a majority of pediatric patients may not be sick enough to be hospitalized, that certainly doesn't mean that they're all completely asymptomatic and that there's no effect from having had COVID-19 on their lives.
Thank you very much, Dr. Lee. Very, very helpful. I think that the picture that we're seeing here is the identification of a rare side effect, which fortunately in most circumstances is relatively mild, and for which the picture of recovery appears to be very favorable, balanced against the impact of COVID-19, which in many circumstances for people who end up hospitalized can be very, very severe. As the ACIP continues to meet today and tomorrow, the FDA and the CDC plan to update the vaccine fact sheets and clinical considerations with some statements about the risk of myocarditis and pericarditis, and to include treatment guidance for medical professionals. They've discussed issuing recommendations for how to proceed with vaccinations for those who present with myocarditis or pericarditis after receiving a first or second dose of the COVID-19 vaccines. The Ohio Department of Health will await those updated fact sheets and guidance, and will then ensure that Ohioans and vaccine providers have access to that updated information. So now we'll go ahead and take questions.
Thank you, Dr. Vanderhoff. Our first question today comes from Dan DeRose with WOIO. Dan?
Good morning, gentlemen. Alicia, thank you for your help. How are you able, or how are researchers able to determine that maybe a child or an individual that shows signs of myocarditis, that they didn't have COVID previously? Or how are they able to determine this was from the vaccine, or this is because they had the illness? And is it possible that if you can't make that differentiation, that it could skew the numbers by saying, oh, this is coming from the vaccine?
Well, let me turn first to Dr. Lee to address it, as he is a pediatric cardiologist.
So I think that that's really the big question that the ACIP and the CDC are working towards, is to really make sure that these cases of myocarditis are actually related to the vaccine and not related to other forms of myocarditis. As I mentioned, myocarditis, we've seen myocarditis. This is not something new. Other types of infections, medications, autoimmune conditions can cause myocarditis. And so I think that's part of what the CDC and ACIP are working, is to gather the information to make sure that these are actually cases of vaccine-associated myocarditis versus some other form that's causing that.
Yeah, and I think one of the things I would add is that the safety monitoring systems that are in place through the VAERS program, and which the ACIP examines on behalf of the CDC, are very sophisticated. And the fact that they can identify a small signal, and we're really talking about a rare situation here. If you think about the numbers Dr. Rajpal shared, if you think about the numbers that were shared yesterday by the ACIP during their meeting, you're talking about a fraction of a percent. So we're really talking about something that happens very infrequently. And yet they're fairly confident that this rare side effect can occur. But again, the other good news is that the national experience so far, looking at the 300 plus cases, has been very favorable in terms of the level of severity. And I think Dr. Lee did an excellent job of differentiating what the very, very severe forms of myocarditis look like compared to the more modest or mild forms. And fortunately, this has fallen into that camp of mild form from which people recover.
Thank you, doctors. Our next question is the last question I have indicated in the chat at this time, and it comes from Joe Ingalls with Ohio Public Radio and Television.
Thank you, doctors, for doing this. I appreciate it. One of the things that I wonder about is we're seeing in the United States, there are pockets of infection that are coming from areas where vaccination rates are very low. We know that kids, like you're saying, very low participation rates in the vaccine programs. Are you concerned that Ohio might have these problems soon, that they might show up in schools or university communities, places where there's large unvaccinated populations? And how do you handle that if that vaccination rate doesn't increase dramatically?
Well, thank you. I think that's a very, very important, very, very timely question, particularly at a time when we are looking at the emergence of a new, even more contagious variant, the Delta variant, which appears wherever it has arisen to rapidly overtake the previous infectious variant, the B117, or now termed Alpha variant. So today, we're looking at a variant that's already in place, B117, that's very contagious, much more contagious than the one that caused our big winter surge. And now it's going to be replaced. That, of course, does cause us concern, but it's a good news, bad news story. The good news, and you alluded to this in your question, Joe, is that if you're vaccinated, you're very well protected against even the Delta variant. Thankfully, our vaccines seem to do a very good job against the Delta variant, especially against the things that we most are concerned about, keeping people out of the hospital or preventing death. But for those who are unvaccinated, they're now facing a virus that has demonstrated an ability to sweep through communities and put a lot of people into hospitals who are unvaccinated. So I think it should be a wake-up call for us. I think it should be a reminder that while we're doing well, and indeed, our first vaccination rates for people over the age of 18 here in Ohio, when I last looked at the numbers, appear to be approaching 60%. That's encouraging. It's certainly not enough to protect. We have more people who need protection. The simple bottom line is that those who are unvaccinated are unprotected against the emergence of a even more contagious variant. I'll turn to my two colleagues, and Dr. Rajapal, maybe you could start with some of your thoughts about this, and then Dr. Lee, maybe you could conclude.
Yeah, one of the biggest advantages of vaccination is prevention of hospitalization and deaths, even in younger individuals. And it is the hospitalized patients that have the highest complications amongst those who get COVID-19, even some of the young ones. We have the risk of myocarditis that we've talked about. There's a risk of heart failure. There's a risk of blood clots to the lung that can cause strain on the heart. And of course, in younger and adolescents, there's the risk of MISC. So all those are considerations which favor vaccine at this point of time.
Yeah, and just to add to that, at the ACIP meeting yesterday, they discussed some of the statistics in terms of who is still having a high infection rate, a relatively high infection rate. And while the adult populations, the infection rate has been going down, and no doubt related to the vaccination, but in the rate in teenagers and adolescents has remained stable, meaning that there's still a similar number of teenagers testing positive for SARS-CoV-2 or COVID-19. And so I think that it's important for us to really promote vaccination in these teenage groups because they're still getting COVID-19. And so, and especially with the emergence of these new variants that may be more dangerous to younger people or certainly seem to be more infectious, I think it's really important for us to promote that.
Thank you, doctors. We do have a few more questions that came in through the chat, and the first one is from Pete Grieve with Spectrum News.
Hi. So the governor, released sort of an update on the death rate this week. 14 per day, 100 per week is what he said after conferring with Ohio Department of Health officials. Dr. Vanderhoff, I'm wondering if you could, I guess, talk a little bit more about sort of that assessment that was done. And if you could talk about, I guess, the element of this being a lagging indicator, as well as any info about whether any of these deaths are from vaccinated people or if they're sort of all unvaccinated people who are dying.
Sure. So great questions. So first, in terms of the comparative impact, of course, at the height of the pandemic, we were looking at hundreds of deaths every week. And now to have our deaths down to around 100 per week is a real improvement. And I think the governor said it very well during his press conference. It's easy for us to develop a new normal in our minds, to accept something that is so much of an improvement as an indication that we're out of the woods, but we're not. The reality is losing 100 people a week from what is essentially a vaccine preventable illness is really tragic. And so what we would really like to see, what we are strongly advocating, is that more and more people who are eligible to receive the vaccine get out and get their vaccine. Now, in terms of, well, how many of these cases that have been attributed to a COVID death by the attending physician who completes the death certificate, nearly all of those cases are the direct result of COVID. And our vaccine breakthrough rates that we're seeing both here in Ohio and nationally, and if you listened to the ACIP meeting yesterday, they did note what I'm about to say, and that is that we're seeing vanishingly low percentages of vaccine breakthrough. Here in Ohio, so far, looking at the dates of March 2nd through June 23rd, we've had 128 hospitalizations among fully vaccinated people, and we've had 19 deaths among fully vaccinated people. In both cases, the median age has been quite advanced, 76 years for hospitalization, 81 years for deaths. Those are vanishingly low numbers, and again, reinforce the incredible efficacy of these vaccines, remembering that with any therapeutic or any vaccination, we never we've never in the history of modern medicine had a vaccine or therapeutic that is 100% effective. So these numbers are remain very encouraging and reinforce the fact that our vaccines are working very well against even the variants. I don't know, doctors, if you have any additional thoughts you'd like to add.
Most of the cases that are coming now to the hospital, even nationally as well as with the state that we are seeing, are amongst unvaccinated. So that's the information we have.
Thank you, doctors. Our next question comes from Maria Durant with ABC6.
All right, can you hear me now? Doctors, thank you so much. I certainly do appreciate it. Just a quick question. I know you've all kind of spoken a little bit about this, but I just wanted to get a bottom line from each of you in talking to a parent who may have a child or a young adult or someone in college when it comes to their fear on getting the vaccine or not and myocarditis?
Sure, I'll start and then I'll turn to my two colleagues. Essentially, I'd say to any parent, of course, as a parent, it's the right thing to do to be evaluating risks and benefits and thinking very seriously about those. But in my medical opinion, the analysis falls so heavily on the side of the benefits of receiving the COVID-19 vaccine that, to me, that seems to be the right choice. Remembering that while it does appear that there is a rare risk, fractions of a percent risk, that especially young men can develop myocarditis. This happens in not only a small number of people, but among the people who do develop it, most cases are mild, and the individuals recover often on their own or with minimal treatment, as opposed to some of the more severe treatments that can occur for people with other forms of myocarditis. So when you weigh that against the risks of the multi-system inflammatory condition, a syndrome of children that Dr. Lee outlined so aptly, when you weigh that against what we know COVID-19 can do to the heart, and Dr. Rajpal illustrated so well, and a host of other serious impacts of COVID-19, to me, the safety of vaccination is self-evident. Dr. Rajpal, I'll turn to you, and then Dr. Lee can close us up on this question.
Yeah, I totally concur. The good thing is, as you had mentioned earlier, that we have excellent data from our surveillance systems. And what those data point out, that even if you look at the highest risk group, which is the age group of 12 to 17-year-old males, per million, the risk of myocarditis is just 70. Whereas the risk with COVID is much higher, about 70 times higher to get myocarditis. But with the vaccine, you prevent 5,700 infections, you prevent more than 2,000 hospitalizations and 2 deaths, even in that age group. Now for females and for the other older age groups, the risk of myocarditis is negligible, whereas the benefits are huge. So when you present these numbers to parents, their concerns are totally valid, but I think we have the data to support the recommendations.
Yeah, and I totally agree with Dr. Vanderhoff. I think everybody should, if you have any questions or have any concerns, speak to your healthcare provider, speak to somebody, and ask questions, because I think everybody should do that just to see, like Dr. Vanderhoff was saying, all therapeutics, all vaccinations, nothing is 0% side effect free. And so it's important to have those discussions. And just to add to what Dr. Rajpal is saying and Dr. Vanderhoff are saying, we've taken care of a lot of children with MIS-C, or multi-system inflammatory syndrome, in children. And these kids come in sick. And just talking to some of these patients and families after they're out of the hospital and just recounting their experience, I mean, it's really incredible. These are healthy children, some of them athletes, never been to the hospital before, all of a sudden coming in and spending a week in the intensive care unit, or in some cases rare, but in rare instances needing to be on a life support machine. And just talking to people after that experience, I think is really the piece of the conversation that I would bring up, because it is, fortunately, it's treatable. It's not, the mortality is low, but then even just also thinking about the after effects of having been so sick, and especially the psychological and emotional burden of having had that experience, I think those are things to think about. Even aside from myocarditis or hospitalization, just what are the after effects of being sick with MIS-C or having persistent symptoms after COVID-19?
Thank you very much. And thank you, doctors. That was our final question. Dr. Vanderhoff, would you like to share any closing remarks?
Well, I do want to thank, first of all, my two colleagues, Doctors Rajpal and Lee, for taking time out of their busy clinical schedules to be with us this morning. Their insights and their clinical experience are invaluable. So thank you, gentlemen. And I want to thank also the members of the press who joined us today. This is an important topic. And I think it's very important for all of us to share good factual information consistent with what has come out of both the ACIP and now the joint statement from many medical specialty societies and health and human services regarding the rarity of this potential vaccine side effect and the good clinical course that we're seeing for most of the patients who do suffer this rare side effect. So thank you all again.
Thank you for joining us. I will now end the meeting. Have a great day. Thank you.
Thank you.